Okay, hello everyone. Welcome to our Ask the Doctor session tonight. My name is Shelly Korean with SkyPass Foundation, and I hope everyone is doing well. Thank you for joining us today. We're here to discuss non-motor symptoms in Parkinson's disease, a very popular, highly demanded topic. And to lead us through this discussion, we are honored to have Dr. Irene Malaty from the University of Florida. Dr. Malaty is a movement disorder specialist at the University of Florida, and she specializes in the care of individuals with PD. And she serves as the director of the Parkinson Foundation Center of Excellence. She is an experienced investigator in clinical trials for PD and has lectured internationally on movement disorders and has published many articles and chapters. And actually, a recent book, Living with Parkinson's Disease, that link to that book was sent out with the email promotions for this webinar. So hopefully, you guys have had a chance to check that out. She is the chair of the movement disorder section of the American Academy of Neurology and is devoted to care, education, and research in PD. Dr. Malaty, thank you so much for being here. We're excited to hear from you. Also joining us today is Dr. Chitnis. Dr. Chitnis sits on the board of directors for SkyPass Foundation and is a movement disorder specialist at UT Southwestern, and she'll be moderating our discussion today. And with that, Dr. Chitnis, take it away.
All right. Thank you, Shelly, for your kind introduction. And Irene's a good friend, and I'm really excited for her to be here. So before we start talking about the topic, I want to ask Dr. Malaty a question as to what prompted you, with your busy career with two little girls and a husband with a busy career, and of course you have all the free time on this earth. What was so compelling that you had to write a book on, living with Parkinson's disease, and how is your book different from what exists currently?
Well, I think that the more that we meet with our patients and talk with our patients, we realize that there's really just a flood of information on the internet, information and misinformation, and people can get really buried. So people can set out trying to empower themselves with what to expect, what to know, what are the tools, and they can really get buried and misled. And we really wanted to have reliable information that was very practical and accessible, but also scientific and medical, and kind of balance that in a way that answers the questions we know that people have asked over and over and over, and kind of put it all together in one easy to digest way. So Michael Oken, my colleague that co-authored this book, calls it a cookbook for Parkinson's. So he wanted it to be, his vision was for it to be a cookbook, as simple to read as a cookbook, just pearls and pointers and, in an easy to read format. So that's what we set out to do.
That's wonderful. But also, when somebody puts together a book, we usually have contributors and then we have editors, but that's not the case. You guys actually wrote this book.
Yeah, so there are three of us. Wissam Deeb is the third, and a lot of times you're right. When you write a book, you kind of gather different people to write the different chapters, and this one we just did ourselves. The three of us did all the writing. Sometimes we consulted with some of our team members for their input, like the physical therapists and so forth. But we really wrote it all from scratch ourselves. And one of the cool things I like about the book too is one of our dear friends is the husband of someone who passed after living a long life with Parkinson's. And he was so touched by the disease that he donated his art, which is his photography of people who live with Parkinson's. And so the pictures are of people who are living with Parkinson's, and we just thought that was a really cool enhancement because he got to be part of it with us.
That's, now that you mention it, that's absolutely right. And, I wrote a review of this book, so obviously I leafed through the book, but, my brain works in very selective ways. And now that you mention, I'm looking at all these wonderful people and, just gauging by their facial expressions, they are patients. And thanks for sharing that. And one of the things that is here in your non-motor book is a quote by Christopher Reeve. It says, once you choose hope, anything is possible. So that's really wonderful. And thanks for putting together this book. And I highly recommend everybody putting a plug in, because I read the book and it was fantastic. So, so coming to the topic today, when do you think non-motor symptoms start in patients with Parkinson's? Like, do they start later in the disease? Do they start many years before you even develop the motor symptoms? What do you think?
It's pretty clear now that, and I think a lot of our patients are aware of this, especially when they look back on their own experience. It's pretty clear that the symptoms of Parkinson's disease sneakily start well before the obvious motor manifestations. So by the time somebody gets diagnosed, they've actually had Parkinson's for some time. And in many cases, the non-motor symptoms may even be there before there's any obvious tremor or slowness or walking changes. And so some of the most early ones that can be clues can be loss of the sense of smell, or sleep changes that cause the person to have movements in their sleep where they're not paralyzed when they're dreaming. We call that REM sleep behavior disorder, or rapid eye movement, the dreaming sleep. And sometimes when we hear those things, they happen years before the person had any obvious signs of Parkinson's. Depression, anxiety, and constipation are three other symptoms that very commonly can be seen even before Parkinson's becomes obvious. So they're there from the very beginning to the very end, and they change as the condition changes. And so we constantly have to kind of watch for those and address them, because they can be very important for a person's wellness.
Absolutely. And I think that's a, very good answer. Which one of these, and we'll list each of these and we'll talk about each one of them, but which one do you, as a movement disorder specialist, find particularly challenging? I think they're all challenging, but if you had to pick a couple.
Yeah, so that's easy for me. The most challenging, I think, is probably fatigue. And not just sleepiness, but fatigue or loss of energy. That one's tricky because sometimes it can be sleep disorders that we can address that make someone tired, because sleep disorders are common in Parkinson's. Sometimes it can be side effects of medication. Sometimes it can be other age-related changes, other health-related changes like thyroid and so forth. But many times we've worked our way through all of those contributions, and fatigue can continue to be an issue. And different studies have been done trying to look for medicines to improve the fatigue, and none of them work very reliably or consistently. So I think it's particularly challenging because it can interfere with a person's ability to really do things that are helpful for their health, like exercise and so forth. Along the same lines, the second tie for first place of challenging will be apathy. So apathy is a loss of motivation or drive or interest. So a person may feel as if, and sometimes the person may not even recognize it, as well as their life partner, spouse, or family. Apathy is sort of just losing motivation or drive to start things. So the person could feel like, yeah, I'll get to that tomorrow, or I really don't have the drive, or maybe they become less engaged in conversation. And this is a problem that sometimes can be due to depression. Sometimes it can be independent of depression. A person can experience apathy because of changes in the brain circuits. And it's especially challenging because if you don't have a lot of motivation or drive, it can be hard to really do things like your therapy exercises or getting regular exercise, getting out and being social and using your brain in ways that are constructive and healthy. So to me, those two are the biggest challenges because we don't have great medicines that fix those specifically.
Yeah, I totally agree. And, being somebody that's lived with an immune disorder, fatigue can be just an intrinsic part of the disease. You mentioned some causes that you can address, but sometimes, and fatigue is not necessarily something that you can say correlates with the severity of the disease, right? It can start in the beginning and can continue through the course of the disease. And so, some of the strategies that you mentioned to try to, do you think exercise would be, it's counterintuitive as it sounds, do you think exercise is a good solution for fatigue?
Yeah, actually, I do. I think that both with fatigue and apathy, the ways around them are that you have to schedule activities independent of your drive and motivation. So all of us have to deal with this when we want ourselves to have healthy exercise habits. If I say, Yeah, the days I come home with lots of energy after work and after wrestling my 2 kids to bed, those are the days I'll exercise. And if it's not going to happen, I'm going to have to say, I will exercise. I'm going to make this, maybe you tell yourself Monday, Wednesday, Friday, maybe you make a schedule, but it's really sort of making those things, necessary. And exercise, aerobic exercise in particular, releases endorphins that make us feel better and have more energy. So initially people may say, boy, when I exercise, I'm just drained, and then it takes me a whole day to recover. But in the long run, people end up with more energy. And the fact is, you do have to pace yourself, and you do have to do what reasonably is feasible and safe within your current level abilities and your resources. Maybe you have a stationary bike and you can do that safely. Maybe you have to do other things like walk. So you have to do what's safe and doable. And also you have to consider timing it around your best parts of the day. So for some people, they do the best, they're at their best on after their morning dose. Other people do better later in the day. So, you can time your exercise and activities to be during your optimal periods, and that can be helpful too.
Yes, absolutely. As I told the patient today that, in spite of a busy clinic day, and after this session with you, I'm still going to get on my elliptical. So you're absolutely right that, this just has to be kind of scheduled, irrespective. Of course, I mean, if you're very tired and, but if you do it regularly, I think the key word is consistency, as you mentioned, and I hope, we can emphasize that for our patients is consistency, regularity is what's going to get to your point, like never fall off the curve, right? Just keep doing it. So thank you. That's very wonderful. I wanted to ask you a question about, sleep. And, we talk about there is a sleep benefit, in some patients, may not be in every patient, but there is a sleep benefit to Parkinson's. And, so some patients will get up in the morning and they'll actually feel much better, although they've not taken your medication. What can you say about that?
I think everybody has sort of different, everybody has their own different advantages. So some people do the best after a rest, and you can use that to your advantage. Sometimes a short nap, not a really super excessive nap, not for hours that will interfere with your nighttime sleep, but some people can take an afternoon brief nap and recharge their batteries and be energized. But in our sleep, a lot of processes go on that we don't fully understand. There's a lot of cleanup of toxic byproducts of metabolism in our brain. There's even just the rest and just recharging. And there's some inhibitory state that lets everything rest and recharge. So I think that it's something that we don't fully understand, but it's something to take advantage of. So if you have that, then you do activities when you have the best advantage of a good night's rest.
Yeah, absolutely. And I've had patients tell me they wake up, they feel very good, and then they start to feel worse after they take their medicine. And what I try to explain to them is that that's when they have actually starting to feel like they've worn off now. And so it takes a little bit of time for their medicine to kick in. So there is always that lag period between feeling better as soon as they wake up and not feeling so good, and then feeling better after the medicine really kicks in. What kind of sleep disorders do we generally, what can you tell our patients about the various type of sleep disorders that we see in patients with Parkinson's disease?
So I think one of the most common is what I mentioned earlier with the REM sleep behavior disorder. And this is so common that it's almost a sign or a suggestion. If someone has symptoms of Parkinson's and we hear they have REM sleep behavior disorder, then we think it's very compelling that it may really be Parkinson's. This is a condition where instead of being paralyzed when you're in dreaming sleep, the muscles can move and punch and jerk and kick, and people sometimes may roll out of bed, or they might accidentally strike their partner, and they may not get restful sleep because it interferes with good rest for sleep. That condition can be important if people are falling out of bed or getting injured, and also because of not getting good rest. And so this is seen in certain conditions in the same family as Parkinson's, and it is treatable. So it's very important if that's happening to talk about it, because sometimes it can be treatable. Another common condition is restless leg syndrome. So this is a condition where people, especially in the evening and especially if they've been sitting for some time, can feel a discomfort or an ants in the pants kind of feeling, like they can't sit still and they've got to get up and move around or reposition. And this also can relate to timing of medicines or medicines wearing off. But restless leg syndrome is also treatable with many of the same medicines we use for Parkinson's and others. Sleep apnea seems to be more common in Parkinson's than in people who don't have it. That's a condition where a person may have some relaxation of their airway and they can almost stop breathing in their sleep. So it'll sound like they're snoring and then they kind of wake themselves up partially. And that causes them not to get restful sleep and may have drops in their oxygen. Again, can cause the next day to be tired, low energy, not as sharp cognitively. Also, people can just have insomnia and sleep disruption. Sometimes that's because medicines have worn off and people have cramping or return of their Parkinson's symptoms that can wake them from sleep. That's probably one of the most common situations. And we may need long-acting medicines at bedtime, or we may need to adjust timing of doses, or even sometimes take medicine in the middle of the night when it's necessary to try to control that. Those are probably the most common sleep conditions in Parkinson's.
Yeah, wonderful. And do you think that you always need to have a sleep study to diagnose all of these, or you can diagnose some from history?
So that question is debatable. My answer is, do I think so? No. But if you ask a sleep specialist, they would probably tell you yes. And we've
Yes.
had this debate before. I was lucky to be invited to be involved with a panel of experts, some in Parkinson's and some in sleep. And we were hashing out the issues of sleep in Parkinson's and reviewing the literature and discussing the issues and the right treatments and strategies. And the sleep doctors think it's actually very important not to just diagnose it by the symptoms, because sometimes the symptoms could trick us to think there's a problem there that really isn't, or to miss other problems that are there. So they recommend having an official sleep study. What does that mean? It means typically spending the night in a lab where there are sensors that track movement, sensors that track the brain waves, the heart, the EKG, so the heart and the oxygen levels, and they will observe the sleep and determine what's going on. Nowadays, they also do some partial sleep studies that can be done at home where a person wears sensors. They're not going to be as good as in a lab, but they can be used for some screening. So they would say that you need that. I would say most of the time when it's in the context of Parkinson's, it's usually the common stuff that we see all the time in Parkinson's.
Very much so. And we're neurologists, so we're on the same side, and I agree. And I think, as neurologists, in the history truly lies the mystery. So if you get a really good history, you don't need a sleep study. Thank you. So, one of the things that patients with Parkinson's disease feel, we're going to talk a little bit about drooling, is that they think they produce a lot of saliva. So although, you and I know that patients with Parkinson's disease actually have dry mouth as a symptom, but, they still drool. And so what can you tell us about drooling and how it can be helped?
Yeah, this is a symptom that we see less commonly in real early Parkinson's, but more along the lines of people who have had Parkinson's for a little while, and they may notice saliva pooling in the corner of their mouth, or even in extreme cases, actually drooling out of the mouth. And it's not so much an issue that you're producing it faster or more copiously. It's more that we all reflexively and automatically swallow all the time, and we manage our saliva production, which is constant, with swallowing so that it goes down. And just like other muscles are slow, we swallow less often if we have Parkinson's. And so the balance just falls out of balance and it can pool or even drool. There are medications that can be used to try to offset or reduce the amount of saliva to help manage it more effectively. Most of those have side effects like confusion or hallucinations. Sometimes we try eye drops that are less, more in the area where the problem is and less in the whole system, so there are less side effects. And one of the most, and even before you go into any medicine, there are tricks. So some of the tricks are to keep chewing gum or candy around, because as long as that's in your mouth, you tend to swallow more frequently. Also keeping a bottle of water and having sips of fluid, that will trigger a swallow, so that helps manage it. And in cases that are very severe and constant, There are some injections we can do that are very effective with botulinum toxin. Some people have heard of Botox. It also has other brands like MyoBlock. It's a different brand of botulinum toxin, and we can inject it in the cheek in the parotid gland and right here in what we call the submandibular gland. Very simple, quick injections, and they work for about 3 months at a time, drying out the saliva. So those are some of the strategies that we try when that happens.
Interesting. I want to just come back, Dr. Malaty, really quickly. Mr. Saxon asked this question. I did answer it to him, but I wanted to, for people, is that can symptoms of REM sleep behavioral disorder include actually assaulting their partner in their sleep?
So when people have this condition, they very commonly have vivid dreams and sometimes combative dreams, or they're rescuing someone or they're fighting off an assailant. They're usually very colorful and vivid. What we see happen in the bed is most commonly kind of gross movements like a flail or a thrust, but occasionally I've heard stories of someone pulling on someone because they thought they were pulling a ball or doing things that looked more purposeful. Now, if you heard a story that sounded like a very specific attack of another person that was very purposeful, then I would be less comfortable attributing it to REM sleep behavior disorder. But whatever the person's dreaming, they may be physically acting that out. So you can see some colorful things take place.
Yes, absolutely. And one of the points that I want to say is, a lot of times patient spouses will leave and go sleep in another room, and I find that to be really sad because the patients need support, and just the spouse leaving because of danger of hitting. So I think it's important to mention these symptoms to the doctor because, as you said, this is completely treatable, right, with the right kind of medication. So very, very important to talk about. Shelly wanted to just know, can you talk about any interventions for apathy per
Well,
se?
like I said, the reason I said it was one of the most challenging is because we don't have an intervention. There have been studies. There have been studies looking at rasadrolene or Azilect and studies looking at different things. If there's depression, then treating depression can sometimes help apathy if the apathy is due to depression. But when it's strictly due to Parkinson's, really structured activity and scheduled social and physical activity is the best strategy.
Absolutely. And so changing gears, talking about one of the most common symptoms that I think practically every patient with Parkinson's disease struggles with, and which is constipation. What can you tell us, causes of constipation in somebody with Parkinson's disease to start with, and then we'll talk about, interventions. So what can you tell us about, the pathophysiology, why patients with Parkinson's get constipation?
Well, I think that some of the changes of Parkinson's occur in the gut and that's part of it. Parkinson's also affects our autonomic nervous system, which is the part of our nervous system that regulates things that move automatically. Another component is less mobility. So if you're less physically active, that can contribute to constipation. Medications can have drying effects, particularly some like trihexyphenidyl or maybe amantadine, maybe many of the bladder medicines that are used for urinary issues can cause constipation. So yeah, I see somebody, Dr. Chitnitz wrote, if you don't move, your bowels don't move. I like that. That's very good. Yeah, mobility is important. And so medicines can dry out our system and cause constipation. And of course, diet. Diet is the most easily modifiable, and dehydration. So most people with Parkinson's, in my experience, need to drink more water, more fluid, and that can help us tremendously because if you don't have enough fluid, things are going to be harder and more difficult to move. Fiber in the diet is very important. So things like fruits and vegetables, bran, leafy vegetables can be very helpful to keep the bowels moving. And if those things aren't working, then you can try using fiber supplements, like things like Benefiber and Metamucil, Miralax. Those things can be used. And of course, there are many prescriptions that can be given as well if all of those natural strategies and dietary changes don't help, and also having your doctor review your medicine list and make sure there's not something that needs to be changed.
Yeah, and levodopa in itself, you may have mentioned is it does cause constipation. So you just really have to, use these strategies. Dr. Dewey has come up with a new strategy. He wants people to drink first thing in the morning, get a liter of water, add a cup full of Miralax, mix it up, and drink that water in the first hour to 2 hours. And he has found great success in patients doing well with constipation. Of course, the patients tell me that means I have to go to the bathroom very frequently. And my answer to that is go when you can, not when you have to. But it's important, and perhaps you can tell us that, just being constipated, what impact it has on absorption of levodopa.
Yeah, that's very important. So if you're having severe motility, so Parkinson's can cause slowing of the gut movements. And when this isn't managed, it can affect the medication absorption because you can have a delay for the medicine to get where it needs to be absorbed. And then you can sometimes have times where a lot of medicine gets absorbed at once and other times it doesn't. So it can affect that. So keeping the bowels regular can help medication absorption. I think somebody asked if Miralax can be used regularly. The answer is yes, it can be used regularly. And there's nothing wrong with that. And of course, fiber in the diet is one of the things that you can always do regularly. I wouldn't recommend using laxatives regularly,
Yes.
but something like Miralax, which is really just giving more fiber so that fluid can be pulled in more effectively into the gut to help move the bowels, I think that's okay.
If I can ask you, do you ever check for Helicobacter pylori in patients with Parkinson's disease?
I don't. So this is a bacterium, Helicobacter pylori, which is really super common. And some really interesting scientists figured out it was associated with ulcers. And then eventually it was found to be more common in people with Parkinson's. Right now, there's a lot of research going on looking at what's called the gut microbiome, which means the types of bacteria in the gut of people with Parkinson's compared to people that don't. In fact, at UF, we have a major study going on right now where they're actually taking a rectal biopsy of people with Parkinson's and without to look at what's different. It's thought that it may even start in the gut and that has a huge impact on the progression. So they're doing this procedure to try to tell the difference. So we'll learn more eventually about which bacteria are actually important.
Absolutely. And what was the question? When do you take your medication for constipation in relationship to the time you take your PD medication?
The two don't have to be, the two can be independent. It doesn't really matter. So Parkinson's medicine, there are some medicines that can interfere with your Parkinson medicines, but not the constipation medicine. So, you can take that any time of day. Probably most people would do it in the morning. They probably don't want to stimulate their bowels close to bedtime. So most people would do that in the morning and just do it regularly to keep their bowels moving, but it's not important how that relates to the timing of a Parkinson medicine.
So, talking about the gut microbiome and the change in the flora, as we know, do you recommend probiotics to your patients? Would that be a good option? Would that help with the microbiome?
Personally, I don't think we know enough yet to make a blanket recommendation like that to everyone, but we have 2 dietitians on our staff and they definitely recommend that, especially if you're suffering with diarrhea, they find that can be helpful. So I'm not against it, I'm for it, but I don't really make that a sort of standard recommendation.
Yeah.
But some people can find those helpful.
Yes, absolutely. And so Mr. Saxon wants to know general dietary guidelines, good sources for PD nutrition.
So right now, what I generally recommend in Parkinson's regarding nutrition is a general balanced diet. So you want to eat the same healthy way that we've always been told is good, which is a lot of fruits and vegetables. If you're going to follow a diet, the Mediterranean diet has the most evidence for helping neurological conditions, including memory conditions. And that involves eating fruits and nuts and vegetables and smaller amounts of meat. Fish is recommended in that diet, small amounts of cheese and meat. And that diet's been found to be generally the most healthy. The most important thing with Parkinson's is that sometimes when you eat a large protein load, it can interfere with the absorption of those doses of medication. And so you may need to take your medicine apart from a large protein meal, or you may need to give your medicine a head start to absorb before you eat it, or delay the timing to be after the meal. Maybe 30 minutes before or 2 hours after might be a good recommendation. Or you might space out your protein across the day instead of in big chunks. Now, when people don't find that it bothers them, like if they, early in Parkinson's, a lot of times people can eat whatever they want, it doesn't matter. But if you find that when you eat protein, it affects your medicine, you may have to adjust the timing.
I guess some studies looking at Mediterranean diet, but it comes down to exactly what you said, fruits and fiber and vegetables and lean meats. Let's talk a little bit about, depression and anxiety. So mood and anxiety in patients with Parkinson's, and, how you would, do you routinely ask your patients about this, or is it something that your patients volunteer? And how do you approach treating them?
So I ask about it every time, and sometimes people volunteer, sometimes people don't know that it's part of Parkinson's and they may not volunteer it. So the changes in the brain in Parkinson's are not only affecting dopamine, we always talk about dopamine, but serotonin is another neurotransmitter that can be involved and can contribute to depression and anxiety. And some of the research we've done with the Parkinson Foundation has shown that depression is even more important for quality of life than anything else, like tremor or walking or anything. And so it's very important that gets addressed because it affects your overall function, your interaction, and your well-being. So depression and Parkinson's is kind of twofold. Some of it is a reaction to the changes that are happening. And that, of course, that's an adjustment. Secondly, it's a physical and biological part of the illness itself. And so in those circumstances, sometimes counseling and therapy can be helpful, but many times we actually do need medication to balance the physical metabolic part of it. The same is true for anxiety. It's the same pathway. Sometimes anxiety relates to medication timing, and when people's medicine wears off, they may have an anxious feeling. And that's a little bit separate from the more global anxiety that we see in Parkinson's that needs to be managed with sometimes therapy, sometimes medications.
Absolutely. So let's talk about blood pressure control and low blood pressure or orthostatic hypotension that is seen in patients with Parkinson's disease. What can you tell us about it?
So again, this partially is related to changes in what we call the autonomic nervous system, our autopilot system that regulates things and keeps us in a balance. And so what happens is that people can not only be high or only low, but they can fluctuate and be very high 1 minute and very low another. And especially with changes in posture. So from laying to sitting or laying to standing and sitting to standing, if the system that re-regulates the blood can be less efficient, and there can be a drop in blood pressure so that when a person stands, they go, woo, they feel woozy or dizzy, sometimes even could pass out. And this is what we call orthostatic hypotension. The medicines we use for Parkinson's can sometimes be part of the problem. They can aggravate the low blood pressures or the drops. So the first most important thing for managing this is always to drink enough fluid. So what your friend talked about with drinking a big, we say 2 tall glasses of water, cold water, first thing in the morning.
Yeah.
Can help this problem tremendously. Removing certain medications that aggravate it can help also. Sometimes if a person doesn't suffer from high blood pressure, they can take a little salt in their diet and it can help. Compressive stockings can be useful. And when all of those things have been tried as much as possible, there are at least 4 different medicines that we can use for that problem.
And what can you tell us about increase in blood pressure when they lie down at night?
Well, this is part of the problem. A lot of the medications that help avoid the drops can actually aggravate that natural problem of the blood pressure going higher at night. And so when this occurs, we have to really have some specialty care involved, because sometimes we have to get creative with using short-acting blood pressure medicines at night when a person's going to lay down, and a different strategy in the daytime. Sometimes we have to let people check their blood pressure and take their different medicine strategies depending what they determine when they check their blood pressure. Sometimes you can elevate the head of the bed to try to help this problem. And so those are some of the strategies that we use.
Thank you. Dr. Malaty, do you think patients with Parkinson's disease have any problems with their vision, any perception, double vision? Is that a part of Parkinson's?
So yes, it is, and sometimes it's not. So it depends for each person. Definitely the same age group that most commonly experiences Parkinson's is also an age group that commonly experiences other vision changes. And so that can include cataracts and glaucoma and other things that are completely independent of Parkinson's. But the way that we have our vision involves muscles. There are a lot of muscles that move our eyes in every direction, and they have to coordinate together. And in fact, Parkinson's can affect the muscles that move the eyes too. The most common problem that happens is what's called convergence insufficiency, which is a problem adjusting from looking far away to looking at something close. And people may experience some double vision from that. And it can actually be quite challenging to correct with corrective eyewear, because it's usually intermittent, meaning it's not the same all the time. It comes and goes. So it can be pretty challenging, but that can be one important aspect. Another, there are some medicines that can have blurred vision as a side effect. So that's always important to look into as well.
Thank you. Why do patients with Parkinson's disease have reduced sense of smell?
Well, I don't know if we fully understand that. We think that the abnormal protein called alpha-synuclein, that these deposits have been found in the olfactory bulb and tract, so the part inside of our nervous system that processes the sense of smell. And we don't know if that could be a sign that Parkinson's is somehow contracted through the nasal passages. We don't know if that's just some unrelated reason why those changes are seen in the olfactory bulb. So these are some of the mysteries that have still not been fully sorted out.
Yeah, absolutely. Let's talk about urinary dysfunction in patients with Parkinson's disease, and especially how it can impact quality of life, affecting sleep at night also.
So like many of the things we've talked about, the urinary system is part of our autonomic nervous system. And so this is one of the most common frustrations that can impact sleep and also even just impact social life. So people can have nocturia, which means having to urinate frequently at night, urgency, and sometimes when people are significantly affected by Parkinson's, if mobility is an issue, it can be very difficult to get up and get out of bed and get to the bathroom fast enough sometimes. And again, there are some strategies that are not pills that can be used. That you can adjust the timing of your fluid intake so that you drink most of your fluids earlier in the day. There are some rehab therapists called pelvic health therapists, and they can give recommendations about even certain things that we eat or drink that can sometimes aggravate our bladder situation. So they call those irritants. They can also sometimes offer exercises to strengthen the muscles of the pelvic floor. And again, there are medications that can be used to control bladder urgency. And they have to be considered along with the side effects. Some of them can cause confusion or hallucinations in some patients. So we have to use them very carefully and monitor for those side effects.
Is pain a part of Parkinson's disease? Is that a symptom that you consider is part of Parkinson's per se?
So it can be. And again, people who get Parkinson's get other stuff too. They get arthritis, they get aging spine, they get injuries. And so it's not always the Parkinson's. And if you have pain in your joints, it's probably arthritis. There may be some aggravation if there are changes in posture or walking that can cause wear and tear in an asymmetric way. Parkinson's pain most commonly is cramping of the muscles, and it most commonly occurs when medicines wear off. So a lot of times overnight, leg cramps, foot cramps with toe curling that we call dystonia, or just spasms of the muscles as medicine wears off. Those are the most common types of pain that are related to Parkinson's. So I usually say if you notice it fluctuates with the timing of your doses, that's a good sign it may be related to the Parkinson's. If it's independent of that, it may be something unrelated.
And then lastly, before we go on to some of the questions that were submitted, what can you tell us about cognitive dysfunction in patients with Parkinson's disease?
So cognitive dysfunction should also make the short list when you ask me what are the most challenging symptoms. That's up there too. And so as we all have cognitive changes with aging, these are sort of enhanced in Parkinson's. And so one of the most common changes would be trouble with word finding, thinking of the word you want to say. So kind of having it just on the tip of your tongue and just feeling like it's almost there, and taking longer to think of what you want to say and longer to process are the most common. In people who have more significant cognitive changes, we can see difficulty with what we call executive function, which is sort of planning and organizing and executing tasks. So people with Parkinson's who experience that problem will do better with breaking things in smaller tasks or doing one thing at a time instead of maybe trying to multitask 10 things at once the way one used to do when they were younger. There are cases that become more severe and even can have dementia, but not every person experiences that. Again, we always look back at the medicine list and try to remove certain medicines can cause cognitive side effects, even some of our Parkinson medicines. So that those medicines have to be reviewed. We have to make sure sleep is adequate, because if we're not getting enough sleep, that can factor into the cognitive difficulties. And there are some medicines that can give a little boost to cognition. I always say they're not miracle drugs, so they don't really prevent the memory troubles or totally reverse them, but they may have a mild benefit and they're worth trying.
Yes, absolutely. And so, Dr. Malaty, I'm gonna thanks so much again. Really helpful tips, and I'm getting some comments from patients. I'm gonna go over a couple of questions that patients have asked. One of the questions is, do Parkinson's medications contribute to sleep problems?
They can. One of our medicines called amantadine, it also comes in 2 other formulations, can cause activation or trouble sleeping is one example. Sometimes the medicines make people too sleepy, but depending on the timing of them, if medicines wear off and a person has a return of their symptoms in some of the shorter acting medicines, that can interfere with restful sleep. So those are some examples of ways they can impact sleep.
And so a patient sent a question. He says that Dr. Norman Doidge, in his book, The Brain's Way of Healing, dedicates chapter 4 discussing the positive effects of photobiomodulation / light therapy. Are you familiar with light therapy for PD patients? And if so, do you recommend it?
So I'll tell you what I know. I'm not an expert in that area by any means, but I can tell you what I know. What I know is that light directly interacts with our circadian rhythms. So that means our 24-hour clock, and it works on a hormone called melatonin, and it stimulates when we see light, it suppresses melatonin. When we get dim light, our melatonin goes up and we get sleepy. That's how our human clocks work. It's also been more recently shown that using infrared light therapy may be able to modulate what's going on in the brain. And there's a bunch of animal evidence that in monkeys and other animal models showed that it could have a positive effect on Parkinson's using this very specific infrared light therapy. Now it's harder. If you shine an infrared light on a rat skull, it's a lot easier to get down into the deep parts of the brain where Parkinson's is most important. But in a human skull, that's a little bit tougher. So we actually have a study at UF by Dr. Dawn Bowers, a neuropsychologist who's trying to use infrared light to treat depression and cognitive symptoms in Parkinson's. And we don't know if it's going to work because she's still recruiting. recently, I just learned today that there's a study starting in France by Dr. Benabid, who's one of the main people who, one of the pioneers in deep brain stimulation, who's actually implanting something inside the skull to do infrared light into the basal ganglia. So because there's some impact in animals, it's starting to be studied in humans. So the answer is no, I don't recommend it because we don't know yet, but I actually think it's intriguing and it's interesting and there seems to be some potential. But we always are optimistic when we hear things with potential, and then we just have our guarded optimism that we wait and see before we globally recommend things. But normal light, like bright light, has been used to treat depression for a long time in some patients. So this infrared therapy is a little bit of a different sort of mechanism, and we'll see what comes of it.
Very, very interesting stuff. And then, as you correctly said, I do remember, light therapy for mood disorders is something that we know. A patient wants to know, do you have PD patients that have problems with hypotension in the mornings that are not influenced by postural changes, just have hypotension with a systolic blood pressure, 70s and 80s?
Sure, and those are easier to treat, I think, because there are medicines that can actually increase the blood pressure. The most important strategy in those people also is going to be to work on that hydration. So if you drink 2 tall glasses of ice water in the morning, it's probably going to help you with the postural part. Now, just the low blood pressure, this needs to be evaluated because sometimes it's the Parkinson, sometimes it's other things, and it can often be treated medically.
Okay, and medications like dopamine agonist and even Cinemet. I mean, in fact, all the medicines that we take for treatment of Parkinson's disease can actually cause low blood pressure. So certainly, possible. Let's see what else we have. Somebody wants to know, do some people take Cinemet at bedtime for less pain, better sleep, or is it wasteful?
Or I missed the very last part of what you said.
Or is it wasteful?
Oh, this is a beautiful question. Thank you, whoever asked that. Because it's a really common one that I hear in the clinic a lot is like, why do I need Cinemet at bedtime? I'm just going to sleep. I'm not going to move. So this is a fabulous question. The answer is our brains like dopamine all the time, not only when we're moving. And so just like for your car to drive, it needs oil and gas and everything. Your brain needs your neurotransmitters all the time. People do, in terms of what a person experiences, sometimes if they don't take it at bedtime, they may have early morning off time, meaning when they wake up in the morning, it's very difficult to move and get out of bed or maybe uncomfortable. And it may be harder for the medicine to get kicked in. Some people wake up overnight with cramps or toe curling or discomfort. So some people take it to alleviate the pain they would get otherwise. Some take it because they will experience wearing off. And some people take it because it helps them get started in the morning. But really keeping a steady level is more physiologic, meaning it's more like what's supposed to be going on.
Absolutely. I think Amy is asking about, I think it's melanin and not melatonin. She wanted to know, how is melanin related to our 5 times higher skin cancer risk, if at all? Should we get levels checked and monitor any intake, or is the substantia nigra at fault?
So what I can say about all that, I'm not sure about the whole 5 times higher and so forth. What I can say is that there is an increased risk of melanoma in individuals with Parkinson's. And at some point it was wondered, could this be the levodopa? And it was studied and determined, no, it's actually Parkinson's with or without levodopa has an increased risk of melanoma. And my understanding is that melanocytes share something in common with the dopamine pathway that I don't believe is fully understood, besides that we know that there's a predisposition. You shouldn't have melanin levels checked. I'm not even sure that's something that can be assayed that's outside of clinical research. What you should have is skin exam. And most primary care doctors, so family medicine and internal medicine, can at least do a preliminary skin examination. And if there's anything suspicious, they'll send you to a dermatologist. I live in Florida, so everybody who's old enough has skin problems that need to be assessed and little bits and pieces that have been removed by a dermatologist. But the truth is sunscreen's important at any age with or without Parkinson's, and having a skin check most optimally by a dermatologist, but at least by a primary doctor. And you can even look at your own skin. Melanomas typically are dark in color. So if you see a mole that's dark and changing or irregular in the borders, those are ones that we specifically feel concerned about. But yeah, it is an under addressed, interesting correlation that's kind of important.
Yes, absolutely. And, in the clinical trial, once we knew that there was a higher incidence of melanoma in patients with Parkinson's disease in future, in clinical trials, they started looking at them more. So if you look at the clinical trials of medications such as Azilect, you probably found more melanoma, and it was not because the medications caused it. It was just that we know now, and we started looking more, Well, Brenda wants to know, will working mind games, problem solving puzzles, etc., help slow down the cognitive decline?
It's not really clear. One time I spoke with a memory expert about this and whether, is it useful to do crossword puzzles? And he told me, well, if you do a lot of crossword puzzles, it probably makes you really good at crossword puzzles. So the statement of that is it's not clear that one thing generalizes to another. But what I say in broad terms is keeping your mind active and keeping socially active and physically active are all the most useful things. I do think cognitive exercise is important. It seems logical, the whole use it or lose it. So I think that ways to engage your brain, including just going out and talking with people and interacting, are very important. It's been shown that aerobic exercise actually has an impact in slowing down memory changes. So that's important too. So the body and the mind are use it or lose it kind of situations.
Absolutely. Medical cannabis okay to try?
So that's not an easy yes or no. And I think we all kind of probably know that. So there's a lot of optimism and interest in this. There's not good evidence that it has any beneficial role besides what we call anecdotes or people's stories that people benefit. My personal impression is that some people find it helps their anxiety, it calms them, or helps them with muscle cramps or sleep, rather than something specifically helping tremors or dyskinesia. When people are calmer, sometimes those things are better. And so I believe that may be the role. The cannabinoid receptors in the brain are in similar neighborhoods to the Parkinson's neighborhoods at the basal ganglia. So there's a potential interest there, but we just don't know yet. We know that in traditional marijuana with THC that there are risks like psychosis and apathy. And those are things that some people with Parkinson's are at risk of. And so we worry about the impact on those areas. I think that CBD without THC is probably most likely maybe safe, but we don't even know because we haven't studied it. But I think that when THC is involved, which is the part tetrahydrocannabinol that has sort of more of the high or the clouding part, I think we have to get real cautious about it. So I like when my patients tell me what they're trying, and many people are using different kind of cannabinoid products, either traditional marijuana, telling me that they're smoking weed, or maybe using prescription CBD products. Some people find it helpful, some don't. So it's not a yes or no answer on that.
I agree, absolutely. And I know we talked about gastroparesis. A couple of people wanted to know a little bit more, and then somebody wanted to know if nuts and seeds are, good for gastroparesis with PD.
If nuts and seeds are
good, are
good?
They good for that?
I think that each person has to probably, it's worth talking to a specialist, which is at least your neurologist. And in some places where there's a dietitian, it's good. If there's a gastroenterologist, it's good. Some people have problems like diverticulitis and other things that they're told not to eat nuts and seeds. Some people who have extreme gastroparesis, that they have a very slow motility of their guts, are advised to avoid certain things that might slow down the gut movement, like high fatty things, for instance. But it is a little bit individualized. Generally speaking, these things should be, there's something called a gastric emptying study where you can eat certain things that have a tracer, and there can be an imaging study to tell how long it's taking to clear. And if you have gastroparesis, it may require medication to manage. You may be advised to eat smaller, more frequent meals instead of large meals that might slow down the gut trying to digest. And so, again, some of those recommendations end up being individualized.
Thank you. And the last question, more questions are coming in. Does a little wine destroy neurons?
Does what destroy neurons?
A little wine.
A little wine. Oh, okay, that's a good question. So I will answer it, but I'll say, like everything, that there is some individual variations in my answer. Generally speaking, a little wine, meaning like one glass, may not be so bad, and maybe people can safely enjoy that. And I always want people to enjoy their life, and if that's something they enjoy, I'm not going to be the one to take it away. However, when you have Parkinson's, particularly when you're on medication, you may be more susceptible to side effects of the medication, interaction with the alcohol, and more risk of falling or being impaired in terms of cognitive sharpness. So you have to kind of weigh those. It matters what medicines are being taken, and it matters how well someone's doing otherwise, whether that's a good idea or not.
Yes. There is no such thing as a little wine. Okay, and my last question is by Amy is, what do you think of Dr. Perlmutter, the empowered neurologist? Is he just a faddish celebrity doctor, or is he the real deal? He seems qualified, caring, and convincing. His popularity makes me suspicious. That's all.
Yeah, I'm gonna sit that one out. I don't know enough about. I prefer to hold back on specific comments on another doc during the call, but I would encourage you to talk with your doctor privately in a one-on-one session, where probably it'll be a little bit more candid about advice. But I don't know Dr. Perlmutter personally, and I'm going to just be unable to really comment on that one.
I think that he probably did the trials also with glutathione. Yes, but I agree. But talk to me off record, and I'll tell you. So thank you so much. I think this is we're made it just on time. These are wonderful questions, but Dr. Malaty, just really enjoyed your style of answering the questions. I think the patients did too. And so thank you again for taking the time and being here. And thanks to all the patients for your questions, and hope you learned a lot. Wait, what do you say?
I said, thank you for having me.
Oh, absolutely. Yes. And
great. Thank you so much, Dr. Malaty. We've gotten a ton of comments from those attending that they have really benefited from today's discussion. So, all right. Thanks, everyone. Thanks again, Dr. Malaty and Dr. Chitnis. Take care, everyone, and have a great night.